In today's case study, we're going to talk about cervical kyphosis. Today's Sunday case study is often an injury that can be missed in the emergency department. We have an 82-year-old male who presents after doing some gardening. He was walking in some wet grass and fell, landing backwards. He suddenly heard a pop in his neck and had sudden pain in his neck. Now, normally at baseline, he has cervical kyphosis, which means his neck leans way over like this. And he has a very rigid and stiff neck, and he can't move it very much. The neck pain was so severe that EMS was called and he was brought to the emergency department. Here is his initial CAT scan. While on the CAT scanner, he began to notice some right-sided weakness, and when he came out of the CAT scanner, he was hemiplegic on his right side, meaning he couldn't move his right arm or right leg. The CAT scan was read as normal initially by radiology, therefore the patient was sent for urgent MRI of the brain and cervical spine. Why did they order an MRI of the brain and the cervical spine? The MRI of the brain was normal, but here's the MRI of the cervical spine. So what was the injury and why was it missed by the initial CAT scan? What is the patient's diagnosis prior to this trauma that led to him being susceptible to this type of injury? What if I told you the patient began to progress to quadriplegic while he was in the MRI scanner? Now, what do we do? Is this reversible? Stay tuned tomorrow and I'll explain the entire case. So yesterday I went through a case of an 82-year-old male who slipped and fell on some wet grass, landing on his back, and he felt a sudden pop in his neck. He presented to the emergency department due to this debilitating neck pain and had this CAT scan. Here is the CT scan that was initially read as normal by radiology. Now, I mentioned in the video that he had cervical kyphosis, or his neck seems to be leaned forward and it's very stiff and rigid, and that matches his CAT scan results. So this is also confirmed by his CAT scan, where you see that there is this bridge of fusion mass all the way across his entire spine, and this is called Ankylosing spondylitis. So what that means is his entire spine has auto-fused together in this leaned forward or kyphotic position. Now, because his spine is auto-fused, it's very rigid and doesn't move. So that means these patients are at high risk of fracture with any low velocity injury, such as a ground level fall. Since he felt a pop in his neck followed by pain, we need to be highly attuned to this as likely a fracture. It's very subtle, but you can see the fracture plane on this CAT scan. These patients are at risk for fracture, as I mentioned, and are also at high risk of developing an epidural hematoma, or a blood clot within the spinal canal. I mentioned that this patient became hemiplegic in the CAT scanner, meaning he lost function of his right side. So that does kind of localize to potentially a brain lesion, which why the MRI of the brain was obtained. As I mentioned, that brain MRI was normal, so they proceeded with going on with the cervical MRI, and it did confirm an epidural hematoma. This is the MRI scan, and the spinal cord is right here. The spinal fluid is this white stuff, and you can see this large fluid collection right here, which is actually active bleeding. If you've ever had an MRI, you know that an MRI can take up to 30 minutes. So he was in the scanner for about an hour, and while he was in the scanner, when he came out, he was quadriplegic, meaning he could not move his arms or his legs. He was taken emergently to the operating room for evacuation of the blood clot as well as stabilization of that fracture. Now, the goal of surgery is really to establish his preoperative alignment and not to try to fix that kyphosis, because you can actually open up that fracture plane more by trying to put him in an abnormal position for him. Here's the postoperative x-ray showing stabilization of that fracture, and we also evacuated the blood clot. Because we got to this patient so urgently, he actually made a full recovery and is now walking again. The key points to take away from this case study is that the patient carried a diagnosis of ankylosing spondylitis, where his spine was auto-fused. These patients do carry a high risk of fracture no matter where in the spine that they are auto-fused, and they also carry a very high risk of an epidural hematoma, so an MRI should be done to evaluate for that. Depending on how quickly surgery can be accomplished, it can be a reversible and correctable cause of spinal cord injury. Because the fracture plane can be very subtle, it is very important for the ER doctor or anybody involved in this patient's care to have a high level of suspicion for a spinal fracture. What's also important as first responders, such as paramedics, to keep these patients in their natural alignment. So if this patient normally is leaned forward, to try to lay him down and keep him on spinal precautions could actually make the fracture worse. So if he normally has a kyphotic spine, putting pillows under his cervical spine or under his neck to support and maintain his natural alignment is really, really important. Let me know if you have any questions about this type of case, and I will see you guys next week.